Hello everyone, and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber. Welcome back, everyone. Today we're having a look at another paper concerning appendicitis, and particularly the risk of conversion to open surgery and outcomes in cohorts of patients that undergo surgery converted to open. We'll have a slightly shorter episode today. There will be no formal teaching, but we'll compensate with a good discussion about the paper. I'll leave you to it.
Okay, thank you. So I'll just formally introduce myself. My name is Daniel Senti. I'm one of the core surgical trainees in King David's Hospital. And today we'll be looking into a paper published in July in the World Journal of Surgery. The title is Conversion from Laparoscopic to Open Appendectomy. It's looking into trends, risk factors, and outcomes. It's a 15-year single-center analysis of 2,193 adult patients. Could you tell us more about the background of appendicectomy, Gio?
Yeah, just a few historical notes more than anything else. I'm sure most of you are familiar with what we do with acute appendicitis nowadays. The first appendicectomy was described quite some time ago now in 1735 by Amiand, concomitantly with the repair of a groin hernia. Is an interesting story. If you want to hear about it, we can talk about it later. The first full description of laparoscopic appendicectomy dates back to 1983, so now quite a few years. And not long after that, in 1992, the first hybrid technique called TULA, or transumbilical laparoscopic assisted appendicectomy, was described as well. This latter technique remains quite popular, especially in kids, especially in the continent, Italy and France and Germany. We can talk about it later if any of you is interested. The chart at the bottom is more kind of a reminder of how the trend from 1999 to 2007 and beyond up to today has been characterized by a significant shift from open surgery to laparoscopic surgery, which applies to appendicectomy as well. I'd say that nowadays 95 to 99% of appendicectomies are started and completed laparoscopically. So in this context, the authors are looking at predominantly people that undergo a laparoscopic appendicectomy, but for a variety of reasons end up with a conversion to open and look at their outcomes. I'll pass the ball back to Daniel for a bit more about the aims of this paper.
Well, thank you, Gio. So what we are looking for with this study is to determine the outcomes of the patients that underwent initially laparoscopic approach, but they had conversion to an open surgery, and identify risk factors for this conversion. Now, this being a retrospective study, we can't really use a PICO layout. However, with this caveat, if we were to talk about PICO, the population that the study is aimed for is adult patients over 14 years old that were diagnosed with acute appendicitis, and we will see how these were diagnosed and how they categorized appendicitis. The intervention we are interested in is conversion to open appendicectomy, and we're comparing this with the fully laparoscopic approach, and also the outcome, which will be postoperative recovery time and the morbidity. Gio, what methods were used in the study?
This is a retrospective study, a retrospective cohort study to be more accurate, that enrolled patients were operated on between 2006 and 2020 in a single center, a tertiary center with a significant historical tradition with laparoscopy in Buenos Aires, Argentina. It includes all patients that were diagnosed with appendicitis, and underwent a laparoscopic appendicectomy. The diagnosis was clinical, and the authors describe this as being supported by abdominal ultrasound or CT in all cases. They don't specify what supported actually means and how many of those cases were actually CT or ultrasound proven. They define complicated appendicitis as appendicitis associated with a perforation, gangrene, empyema, abscess, or peritonitis, identified obviously at laparoscopy. Back to Danny for a bit more about the methods.
Thank you. So, as Gio said, only the laparoscopic operations were considered in this study. So, if there were any open operations, primarily, they were not included. And the surgical technique was standardized. So, the time for surgery was standardized as well. All the patients that were diagnosed with the help of ultrasound and CT, along with the clinical suspicion, they were operated on within 12 hours of the diagnosis, and they operated on all the patients with appendicitis. All these operations were performed by a surgical resident with some level of senior supervision, which is not really specified, but we'll get into that as well. The data they have analyzed included age, gender, body mass index of the patients, how fit they were at ASA score, their comorbidities, if they had any operations previously, the grade of appendicitis, time of operation, complications during operation, length of stay, and if they needed to come back later. Could you walk us through the results, please, Gio?
Yeah, let's start having a look at the results. So as the title of the paper hints at, the patients included were 2,193. The vast majority, 2,141, had a full laparoscopic appendicectomy, and 52, so about 2%, were converted to open surgery. The normal appendicectomy rate was about 5%, which, depending on how you see and interpret their inclusion criteria, could be high or could be low. We don't know how many of those patients actually had imaging proven appendicitis. If all of them did, 5% is probably quite high. If obviously not, and I assume that it is the case, 5% is probably reasonably good. And as you can see, there are quite a few significant differences between the two cohorts of patients. So the patients that had a full laparoscopic appendicectomy, the patients that undergo a conversion. Obesity, particularly, is much more common. Previous abdominal operations, complicated appendicitis, and peritonitis. And all these three factors are statistically significantly associated on multivariate analysis with an increased risk of conversion to open surgery. Operative time is a bit longer if you end up converting, and intraoperative and postoperative morbidity are higher overall in the converted group, and we'll go into some more details about that later. Back to you, Daniel, for more results.
For the more results, we'll look into why these patients have to be converted. So as we can see on the first part of this table, the reason for conversion of appendicectomy was most of the times because the base of the appendix was perforated. So this was present in 28.8%. The next reason would be adherences of the appendix, followed by the base not being recognized and an appendicular plastron, which was identified both with 11.5%. Now, other reasons which are not described in the paper made up to 28.8% of conversion rates. And if we look at the intraoperative complications, the open approach had a higher percentage, which is 3.8%. But it's difficult to assess because of the low number, the cohort of the patients that underwent intraoperative, which had intraoperative complications, which were two. One of them had bowel injury, and the other one had retroperitoneal hematoma. If we look at the fully laparoscopic approach, the most common complication was foreside bleeding. 10% had this, and then bowel injury followed by retroperitoneal hematoma and bladder injury. What were the postoperative outcomes? We'll get to that in just a second. This graph is actually looking at conversion rates during the time. So as Gio said, they started the study in 2016 going for 15 years. And we can see the conversion rate actually getting lower in time with a spike in 2020. This was speculatively attributed to COVID and with late presentations, patients that were probably more complex, that they needed conversion to have their appendix removed openly. So what were the post-operative outcomes, Gio?
Well, yeah, this table summarizes most of them. As you can see, readmissions were pretty much equally common in the conversion cohort and the full laparoscopic cohort. There's a few caveats here and a few things I would like to highlight. In terms of readmissions, 38 of those were due to an intra-abdominal abscess. However, in total, there's 80 cases of reported intra-abdominal abscesses. That means that roughly half of them gets managed on an ambulatory basis, which I think is quite interesting. And wound infection, which is kind of the second benchmark I use, at least for myself, to determine the quality of appendix surgery, is pretty much in line with what you would expect for a laparoscopic appendicectomy. So I tend to quote to my patients anywhere between 2 and 5% chance of either an organ space infection or a skin infection. And these numbers pretty much match. They are significantly higher in the conversion to open group. The organ space abscess frequency here is higher, probably as a reflection of the fact that those patients had worse appendicitis. But the wound infection rate is probably a reflection of the technique. Well, most certainly is, as you would expect, being the appendix passed through the wound for the wound to be more likely to get infected, as there is no splinting from a retrieval bag. And most often a wound protector is not used. If we look at the overall complication rate, split by Clavien-Dindo, 1 to 4, as you can see, low-level complications such as Clavien-Dindo 1 and 2 are much more common in the conversion group. However, as we hit Clavien-Dindo complications of type 4, which are the most severe ones, then the difference doesn't really persist or is not as significant. Ball, back to you for some more about limitations.
So the limitations that the author reported, obviously this being a retrospective study, it has the nature of particularly susceptible to the effects of bias. There's quite a good number of cases overall. However, it was quite a small number of patients that underwent conversion to open appendicectomy. And also the results, as they say, may not be generalizable to other centers. This being a center that historically has been vastly trained in laparoscopic surgery, it might not be the same in other centers which are less fortunate in this case. Gio, what other limitations did you identify?
Well, yeah, I mean, having looked through the paper, we thought about a few other things. Well, one thing we already highlight is predominantly related to inclusion-exclusion criteria. It's very unclear how imaging was considered in terms of inclusion-exclusion criteria, and we should probably ask the authors a bit of information about that. Furthermore, we don't know really what was the overall cohort of patients that had appendicitis in that institution and how many first-hand open appendicectomies were performed in time. I suspect you should probably see an inverted type of trend compared to laparoscopic appendicectomies, but you don't know for sure. It's very unclear how the author extracted the data. Hard to say whether they went from a set of codes for operation notes, whether they had somewhere a maintained data set, or whatever, and that does raise some questions about the data quality as well, because obviously with this not being a pre-planned cohort study, the reporting of certain variables, particularly intraoperative, can be sometimes difficult to extrapolate. Maybe you note that there is pus in the pelvis and pus in the right upper quadrant. That does potentially count as peritonitis. Would you necessarily write it in your op note once you've done it and you washed it out? Not necessarily. Would that possibly affect the quality of the data here? Probably. The authors do say very clearly that they do operate on everybody that they think got appendicitis, whether that's imaging proven or not. They don't really offer conservative treatment to these patients. So the compatibility with the legal framework that we've got here, where we are kind of mandated to talk about conservative treatment, is probably not there. Very unclear from the paper what grade of surgeons were involved in the operations and what supervision was provided, whether that was directly in theaters, remote, etc., etc. There certainly is a learning curve for laparoscopic surgery. I believe every training has experienced that. And certainly it's hard to say without knowing the level of the surgeons involved and what sort of the background of those surgeons is, how that affected the study, particularly in the early phases. I'd say that the attribution of conversion rate, higher conversion rate to COVID is certainly a possible explanation, but not necessarily the only one. And finally, a note about how I would have represented the data in time, longitudinal data in time, if I had been contributing to this paper. And I would have used statistical process control charts because a statistical process control chart allows you to identify when a particular type of process goes out of control, whether in a positive way or in a negative way. So it would have been easier to probably visualize when laparoscopic appendectomy actually took off, and if in particular time points there were significant changes in the conversion rate, both in positive and in negative. I think the correlation matrix that they designed is certainly helpful, but it doesn't allow for that type of visualization and analysis. Ball to you, Daniel, for some conclusion.
So, in conclusion, what the paper tried to emphasize on, and what was the message that we got, is that the adult patients that have a higher risk of conversion rate. So, previous abdominal operation, obesity, complicated appendicitis, or peritonitis, they should be thoroughly advised about the higher risk of conversion. And in the table below, we summarize what we discussed with the positive and the negative aspects of the study.
As usual, a quick summary about the discussion we've had after the paper presentation. First of all, we reiterated some points that were made during the presentation, particularly the importance of understanding how many appendectomies were overall performed during the study period and how many of them were started as open surgery, to understand what the overall cohort looks like and what trends look like for open surgery itself. We then discussed the importance of clear inclusion criteria and the importance of imaging as part of the diagnostic process for appendicitis. We reiterated some of the factors that do affect external validity of this study, particularly application to the UK, such as the importance of offering conservative management as part of treatment for appendicitis to patients, as this is mandated by the UK legal framework. A further very important point for discussion relates to the relevance of the findings of this study to the general surgical practice. And overall, we did agree on the fact that there's quite a lot of evidence to suggest that risk factors identified in this study as associated with conversion to open surgery were already well known beforehand. And finally, we touched upon a very important point that applies to the vast majority of retrospective cohort studies, and that has to do with the quality of the data included in the study itself. This relates to both the classification of acute appendicitis and the diagnosis of peritonitis, as this is probably being estimated from operation notes, and operation notes are intrinsically variable depending on who's writing them. Furthermore, we do understand that the technique was standardized for all acute appendicitis. However, there will surely be some technical variations that have not been included within this particular description of the laparoscopic appendicectomy technique. Finally, we do have to ask ourselves what was the purpose of the initial laparoscopic approach. There's a big difference between an unexpected, unplanned conversion to open surgery and, on the other hand, a diagnostic laparoscopy followed by a pre-planned open appendicectomy. And that would obviously skew the results in a significant way. We'll ask a few questions to the authors and we'll let you know. See you next time. Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.